and have this on YouTube. So one of the things about me as a program director is unique to me is I actually was a resident here too. And so I had the opportunity to rotate down in Roanoke. And I think a lot of the things that we learn as residents here at UVA comes a lot from the Roanoke experience. For two reasons. One, because you have a different group of faculty there, a different perspective. And two, it's just a different way of practice down there. So I think it's really helpful to have an experience like that in the residency and I'm going to. But tonight is really my true pleasure. One of my mentors, and whenever I'm in a pinch, in a trauma situation, I always just wonder what would Dr. Shuler do. Probably one of the slickest guys around when it comes to taking care of complex periarticular fractures and femoral fractures and pelvic fractures. So it really is my honor to introduce Ted Shuler, who's the program director down at Roanoke, and has been there. I don't even know how long he's been down there taking care of our residents and seen a lot of us come through. And so it really is an honor for me to introduce him. He's going to be talking about femoral nail fractures and nailing femoral shaft fractures. So I think it's really good. So Dr. Shuler, the floor is yours. Thank you for being here.
Well, thank you, Winston. It's a pleasure to be here. And so we're going to talk about antegrade, retrograde femoral shaft nailing and try to cover the femur from top to bottom in 20 minutes. So we'll go over some high points. Obviously, any one topic here could take an hour. So we'll talk a little bit about history, biomechanics, hardware, and technique. So femur fractures are actually fairly common, about 1 every 10,000. The demographics are very important. Generally less than 25 or older than 65. And that's important because the patterns of injury do parallel the mechanism and the bone quality. Femur fractures are fairly impairing and disabling conditions. And on average, the length of hospital stay is 25 days and reduced activity for 107 days. So in 1945 was Dr. Kuncher, who Time magazine published an article about flyers coming back from the war who had femur fractures that they were fixing. And initially they were talking about this being war crimes and then realized that actually this is a better way to treat things. The nail was a straight nail with 3-point fixation, and it was a slotted nail. It did not have any locking. So it really did not have a lot of traction in the States for many years. Locking IM nails started getting in the early late 70s. The one that got popular here in the 80s was the Gross-Kempf nail, and that was a closed section nail. So the upper part of the nail was a closed section or solid, and the lower part of the nail had had the slide in, the upper part was closed. So there was actually a stress riser there. And early on in nailing, metallurgy wasn't as good. There were a lot more failures. So in an effort to try to introduce stiffer nails and have less failures, closed section nails came into play and things advanced. So nailing has shown that it's a major advance due to improved care of the soft tissues. There's less incision, closed management of the zone of injury due to closed reduction, not open reduction, improved biomechanics of nails versus plates, and early weight bearing. So mechanically, you have the force times distance, and with a nail, the distance to the midline is narrowed compared to a plate. So the bending moment on a plate is greater than it is on a nail. Biomechanics are determined by the nail design, the number and orientation of locking screws, distance of locking screw from the fracture site, reaming or non-reaming, and the quality of bone. IM nails are assumed to bear most load initially, and then as it heals, then it transfers it to the bone and the bone takes over load. And one thing that wasn't in this slide is nail diameter. So remember that bending stiffness is the radius to the third power. So increasing the nail diameter, going to a bigger diameter nail definitely helps increase your bending stiffness. So bear that in mind. So there's been a progression over time with regard to hardware and technique. So now we have a variety of implants. We have so-called reconstruction nails. I'll go over that. Cephalomedullary nails, retrograde nails. A variety of entry points are now described that tailor into which kind of implant you're using. And then in terms of reaming as a technique, you can think about unreamed nailing, formally reamed nailing, and reaming to sound, it's called, and I'll go over that as well. So various nailing options include proximal femoral nails. You can have the piriformis entry point versus tip trochanter. Reconstruction, the cephalomedullary nails, gamma type devices, and you have 1 versus 2 screws into the head and neck. And then retrograde nails can have so-called shaft nails or AR nails versus the supracondylar femoral nails. So in terms of the deforming forces, the iliopsoas causes flexion of the proximal fragment. The gluteal muscles cause abduction. Adductor muscles shorten the femur. And of course, these are the forces that have to be overcome to reduce and nail the femur. So here's a case of a AK-47 gunshot wound from lateral to medial. Exit wound was down here, pretty much vaporized the femur. And with the nail in place, you can see the size of the exit wound here with the staples. And she went on to heal very nicely, considering her injury. So here are some of the screw patterns that we have available to us nowadays. So in that previous example, you saw the 2 transverse locks. The old GK nail had that greater to lesser lock. You can have varieties where you have both of those. The reconstruction nails have the 2 screws that go up, depicted here. And you can even put the recon screws in and put a separate lock in. And the cephalomedullary nails, gamma type devices, trochanteric femoral nail, are these type implants. We have 1 large lag screw, and then you have the implant. And going from the retrograde profile, this is a supracondylar nail, so you have an array of 4 screws in different angles. So that lets you get down and treat injuries that go into the knee joint and get low, as compared to a shaft fracture where you don't have to do all the complex locking distally here. So an important concept is length stability. So Winquist and Hansen published their results on a varying amount of comminution. So the important thing here is it length stable and is it rotationally stable? So back in the day, people would go to extreme lengths to avoid doing distal locking. There were even companies that made implants with these little butterfly devices that would protrude out distally so you didn't have to put distal locks in. And now the second-year residents are better than many attendings at putting locks in. So this is not so much of an issue, but people were trying to figure out what is length and rotationally stable to try to avoid putting a distal lock in. And now we recommend locking everything pretty much proximal and distal. So the important thing is that these type 3s have the larger butterfly. You have less than 50% cortical contact, so these are not rotationally stable. And then the more comminution you have, it can be a challenge in determining length of the femur. So if you have a mid-shaft fracture, you can go antegrade or retrograde. The proximal or distal third fractures, we generally approach by what we call short segment nailing. And that means that it's in the proximal third, we go antegrade because it's easier to control the short segment to the long segment in general. And in distal third, we go retrograde, and that improves the alignment, improves the technical steps in doing the surgery. It's important to have good quality x-rays preoperatively, and a traction internal rotation view can be extremely valuable in helping determine, particularly the proximal femur, the pattern of injury and what you have to work with. So antegrade femoral nailing has the longest follow-up, the largest volume, and it's reproducible. Union rates historically 97+%. Infection rates are low at less than 3%. So initial management is going to be with traction pin, balance suspension. In general, hair traction and those type of things should be viewed as EMS transport tools and not something to be done in-house. And also you have to think about the need to determine pin placement, whether the pin needs to go in the proximal tibia or the distal femur. Timing of surgery is going to be dependent on resuscitation of the patient, other injuries including abdomen, chest, head, and whether it's an isolated femur fracture or not. So-called damage control orthopedics is an important concept. Early stabilization in polytrauma patients is beneficial. Numbers of historical studies have shown the benefit of that. Johnson showed that the incidence of ARDS increased with increasing ISS and a delay in fracture stabilization. And we have to relearn some of these lessons, because it seems like nowadays the trauma services are more prone to unclear patients or not clear patients for surgery because of some lab value or this or that, when in reality we can help the patient and we can help them physiologically by stabilizing them. You do have to realize, though, that there's certainly is a select group of borderline patients that are not going to tolerate extensive procedures of blood loss, and so-called damage control, spanning frames, and stage care is very appropriate. So the choice to nail depends on the fracture configuration, particularly at the proximal and distal ends. In terms of nail versus plate, the choice of nail depends on the fracture location and other injuries, obesity. So you have to think before just jumping to nailing the femur. Antegrade versus retrograde comparisons show that there is not that much difference in the two. Early on, there were more non-unions with retrograde nails, but some of that was because at that time there were more unreamed nails and small diameter nails put in, and that reflected in the some of the union rates in retrogrades. But in general, antegrades, you're going to have more hip and proximal thigh pain, a greater incidence in Trendelenburg gait. Retrogrades, more symptomatic distal hardware, and higher dynamization rates with the smaller nails have been shown historically. With reaming, static locking is not a problem. Obese patients definitely are better retrograde. Antegrade OR time 94. In the obese category, and look at the retrograde fluoro time, much less. So retrograde nailing is definitely easier in obese patients. Antegrade with a fracture table may give superior alignment than retrograde with the leg free. So in proximal third injuries, again, we generally go antegrade. Distal third injuries go retrograde for better alignment. Reduction and starting points are the keys. All good nailing starts with good entry points. If you have bad entry points, it's going to make the case much harder and much more difficult. It can lead to malreduction. Subtroch fractures are a particular problem with regard to entry points. So we generally teach a triad of entry points nowadays. So the traditional piriformis entry point is back here. That is the entry point that is going to be most in line with the axis of the femoral shaft. So remember, the center axis of the head and neck is not collinear with the center axis of the femoral canal. So that's why if you're doing recon nailing and your entry point is back here, so a recon nail typically is not going to have a valgus bow. You'll use a piriformis start. That's why to get to the task of getting to the center of the head, you often have to drop your hand so the targeting arm is much closer to the floor. If you're doing traditional cephalomedullary nailing and you're out here in the tip trochanter, then you're more naturally in line with the femoral neck, and that makes that lock a lot easier. And then we talk about the so-called hybrid entry point or trochiformis entry point, which is generally kind of in this location. It's on a vector between the tip trochanter and the piriformis entry point. And they all have some merit. So in this case, this is more of a proximal femoral fracture, subtroch fracture. And so you really want to be collinear with the center axis of the canal. And so in this case, with the hip abducted, it covers up the entry point, which makes it harder. So you have to do some things if you're going to do this case to get the femur out in position or get an inside out entry point in order to get a collinear entry point. Otherwise, if you get too lateral, then you're going to end up with varus. And in this one, a bad flexion deformity as well. So the tip trochanter or slightly medial to the tip is generally the site of choice for antegrade nailing of subtroch fractures and for most general nailing of proximal femoral fracture patterns such as reverse oblique intertrochs or intertroch fractures. And in general, a little more medial is always a little bit better than too lateral, because you can always lateralize it. And particularly in softer bone, the more you ream, it generally will lateralize itself some. So again, retrograde nailing has advantages. It's easier in large patients to find a starting point. It's better for combined fracture patterns, particularly ipsilateral femoral neck, tibia, acetabulum fractures, patella fractures, their associated knee injuries. And when you ream it and you get a good fit, the union rate is basically the same as antegrade nails. So potential disadvantages of the retrograde nail as a starting point, particularly you have injury to cartilage and patellofemoral mechanics, but with proper placement, that's not a concern. So various studies have shown that there are no deleterious effects on the patellofemoral joint with a properly inserted retrograde nail. And the literature does not support decreased knee motion or increase in knee pain with a retrograde nail. And so this slide shows one of those studies, and you can see the different contact zones and degrees of flexion. I do generally recommend trying not to ream much bigger than a 14. In older patients, you certainly can get bigger than that, but you start getting much bigger than a 14, you start getting into that 90-degree footprint a little bit. So for technique of retrograde nailing, you want to use a radiolucent table, knee triangles, open medial peritendinous approach, or even formal arthrotomy, depending on the case, and 45 to 50 degrees of knee flexion is needed to really be able to do nailing safely retrograde. So starting point in the lateral, so you want to be just above Blumensatz's line. If I'm doing more of a supracondylar fracture, depending on the case, I'll often even get back into here and try to parallel the posterior cortex. In terms of an open view, this is from the book. We generally kind of tend to recommend a little bit more of a medial entry point because the anatomic axis of the femur actually comes out medial. So if you're like looking at it, you want to be a little bit more over here toward the medial femoral condyle. Or sorry, that's more here is medial. And again, here's another book image. I like that entry point there pretty well. Could even be a little further back, but on the AP, you're right centered in the notch, and that probably actually is not medial enough. So beware the very distal fractures. They can have fracture lines that extend into the intercondylar region. Some things you can do to help yourself. You can tap the knee. If for some reason you don't have a CT scan, if there's blood in the knee, you might be more concerned that there could be an intercondylar split. And just go ahead and do a formal arthrotomy, and you can address anything you need to. One advantage of retrograde nailing, and this is an older case, as you can see, this is actually a AR nail or a straight nail. It doesn't have the bend for supracondylar, doesn't have the other locks. But in this case, I made a window with front and back screws and then did some other periarticular work and put the nail up through there. So depending on your brand, though, these things can be a big deal. So you need to know the locking group and the brand that you're using. So you generally want to place the knee locks first when you're doing retrograde nailing, because as you impact, you're going to shorten the fracture and then pull traction through the handle for length and rotation, and then get your proximal locks. And the dog has gotten in the room here, so she needs to get out. So I'll show Ginger. Ginger, you want to give a lecture on femoral nailing?
Yeah, that's awesome.
Come on.
That was fantastic. Good stuff, Ted.
So again, place your knee locks first. Use an adequate incision when you're putting in your locks. Don't get crazy with incision though, because you are near the lateral femoral circumflex vessels up there. I like to use a lasso. I generally have not found a mechanical device that locks into the screw that I'm happy with, that I really don't worry it might disengage. Plus you lose feel of being able to come on and off the screw to tell how close you are to the bone. So I think a lasso and just being careful is important. I generally try to leave my locks or the tip of my nail around the lesser trochanter. So if I have an ipsilateral hip shaft, I do have access to the neck. Colleagues want to run up into here, and I think that that's fine. But I generally try to tend to be at the lesser trochanter level, somewhere bracketing the trochanter. If you do get too short, though, it is hard to place that front to back lock in isthmic bone that's very dense. So going on to reaming, and reaming can be done several ways. This is showing a straight reamer. And this is depicting a flexible reamer over a guide wire. So there are a number of advantages to reaming. The nail will not get incarcerated and have higher union rates. You get a more durable fracture nail construct. And of course, that can lead to earlier weight bearing, the more stable construct you have. So in thinking about reaming, you can use formal reaming, which means you pick a nail size and ream up the fit. So you can say, I'm going to pick a 12. I've got enough room. I'm going to ream to a 13.5, and I'm going to put a 12 nail in. You can also do unreamed, where you say, I'm going to just put the smallest diameter nail I have, put a 9 in, and just pick the length. And some people have used that of late as a damage control orthopedic method, just putting an unreamed nail. I think if you're doing damage control, I wouldn't advocate that, because as we'll see, any manipulation you do to the femur does generate some emboli. And then a more modern concept is using the reamer as a motorized sound. So you pass the reamer, ream to whatever the desired amount of chatter is, and then pick a millimeter or two smaller diameter nail. And that way you know you're not going to get the nail incarcerated. So Pape in the early 90s caused a lot of concern about reaming because of his studies that showed possibility of association of ARDS in people with pulmonary trauma, fat embolism. However, later animal and clinical studies have completely refuted that. And there are a number of studies that show that the thoracic injury is the major determinant of pulmonary complication, not the use of a reamed IM nail. There are potential negative effects of reaming, though. Reaming does destroy the intramedullary endosteal blood supply. The periosteal blood flow increases to compensate. The medullary blood supply does get reestablished over 8 to 12 weeks if space is left or in the canal by the implant. So most of the implants will have scallops or cutouts to allow revascularization. Unreamed nailing does decrease blood flow less, and the restoration of endosteal flow is earlier, but it's equal to the ream canal at 12 weeks. But unreamed nails do generate fat embolism. So all patients with femur fractures have fatty emboli, but not all patients develop fatty embolism syndrome. So anytime you have opening pressure, you're going to have fat embolism. So here's a study showing fatty emboli. So putting a centering pin in, putting the cannulated cutter in with a spike, and then putting a nail rod in. Various studies, again, looking at femur fracture reaming pressures. Every time you're passing the reamer, you get spikes. Then when you put the nail in, you get a spike. I did a study with one of the UVA residents, Tim Misek. We did transesophageal echo and reaming. And this is a transesophageal echo of a patient with rod insertion. And this is the fatty emboli that was, we could actually watch this snake through the heart on this particular case. And you can see a snowstorm. So all this snowstorm effect is part of the emboli. What is interesting when you actually do these studies and see this is not everyone gets the big particulate emboli. Most everybody gets this snowstorm effect. And I wonder if some of the people who have the more deleterious effects are the ones who are getting the proportionally larger emboli and or a larger volume of emboli across the right side of the heart. So you do have to consider the fact that there can be negative effects of even unreamed things. So definitely most of us consider the motorized sound concept as what we use the most. Ream until light chatter, and then pick your nail smaller than whatever reamer you stop with. Generally, in the femur, you want a millimeter, millimeter and a half is generally what I go for. but definitely millimeters is smallest. In the proximal femoral nails, I tend to go 2 millimeters larger with the reamer than nail diameter. It's very important in reaming to maintain the alignment and the reduction while you ream. The nail is going to seek the reaming pathway. So you can't just put the guide wire across, let it sag, ream it, and then put the nail in and expect to magically line up. It won't do that. So we do recommend statically locking all nails. Brumback showed that 98% union rate with a statically locked rod. And femur fracture complications certainly occur. Hardware failure, non-union, malunion, infection, and various neurologic vascular injuries, heterotopic ossification. But generally, it's a very safe and effective procedure when one pays attention to detail. So that's that. It took about, what, 25 minutes, so not too bad.
Perfect, Ted. If I could nail a femur faster than that. Question for you from me. That vaporized femur you showed, how on earth did you figure out how long to make it, how to rotate it? How did you do that? Or what give us some advice.
Well, there's several ways to do it. The easiest way to do it is measure the other leg, and just put the patient's legs out. With that kind of case, you can scissor the other leg down. So just measure from the top of the trochanter to the top of the patella, and that gives you a good idea. And then when you're on the fracture table on the other side, you just crank it out to where, you get that length. We actually had a protocol that we used for a good while where we used a CT scanogram for femoral length preoperatively. So if they were going into the scanner for other reasons, the techs would spin the other leg and just give us a length. They would give us a length from the tip of the trochanter, top of patella, from the piriformis fossa to the top of the patella. And with those techniques, you rarely miss size a nail.
That's great. One of my favorite things about Roanoke as an attending is the residents, when they come back from Roanoke, get to show me how to do the right stuff. So like Max and Michelle, I think are on the call right now. They're both chiefs. And whenever I'm getting the weeds, I'm like, well, what would Dr. Shuler do? Like, well, they just do it like this. And then it makes it a lot easier for me. So any questions from the audience? You're welcome to put them to the chat, or you can just raise your hand. I can call on you. Otherwise, I think Zach Burnett has some cases he wants to show. So Youssef, do you have a question? You just want to go ahead and unmute yourself and ask?
Sure. So if I heard correctly, when you were speaking about the order of locking, you spoke about with antegrade nails that you lock proximally to distally. But I've seen instances where they lock distally first when they have a gap in the fracture, and then after they lock distally, they use a mallet to close that gap. So is there any disadvantage to that order?
Yeah, so if you have a pure transverse pattern, back slapping concept definitely is worthwhile. Most of the time in the trauma world, you're going to be dealing with highly comminuted fractures. And of course, if you try to back slap, you're going to lose leg length. And the femur generally wants to heal. So if it's a pure transverse pattern and you have a gap, then yes, you definitely want to change your technique and do that. But you have to be very careful that if it's a short oblique or any kind of injury pattern like that, if you try to back slap it and shorten it, you're also going to have malrotation with it. So in general, most of the time, again, when you're going antegrade, you're driving, going retrograde, you're driving, you generally aren't going to distract. You usually are compressing.
Great. Lisa,
depending on combination.
Yeah, I have a question. When you have like a periprosthetic fracture about the knee, what are your indications to know something's going to be more amenable to something like a retrograde nail versus like a list plate? How do you make that decision?
Well, the biggest decision point is going to be closed versus open box for the implant. In our hands, many institutions will not nail, but as long as it's got an open box, there are very few that you can't nail.
Yeah.
There are a lot of tricks. So the thing you have to realize, if you are going to be, once you start expanding the indications for nailing, there are a lot of tricks that go with that, and you have to dedicate yourself to knowing the tricks. And it's technically harder to nail than it is to plate. But once you learn it, it's more versatile. But plating is definitely easier than nailing.
Awesome. All right, Zach, go ahead, man.
All right, sounds good. Can you guys see this? All right, sweet. So I put together just a couple cases that I had seen that had come through UVA, hopefully reiterating some of the stuff Dr. Shuler had touched on. And there are a couple questions that come up, so feel free to jump in. It's gonna be too hard for me to pick people out, so if you know the answer, feel free to jump in.
I'll take it. Don't worry.
So the first one was a 38-year-old gentleman who came to the ED after he was trying to cut down a tree, and him and his buddy were trying to pull a branch down with their pickup truck, and it didn't work out so well. The branch ended up hitting him on his leg. He said it, impacted directly on his lateral thigh. He immediately had some pain there and wasn't able to walk anymore. Healthy guy, no real medical history. When he came into the ED, he had some abrasions that were noted over his lateral thigh, no obvious open injury. Did have diffuse swelling of his thigh, but otherwise no other injuries noted. He was neurovascularly intact, had good pulses distally. So these were his films that we initially got when he came into the emergency room. Someone want to jump in and tell me kind of what you're seeing here? And
Raise your hand, I'll call on somebody, or it's pretty easy, man. It might get harder from here, so I'll jump on this one for you. Nobody. All right.
Like we've got an AP and a lateral of the right thigh. In a skeletally mature individual. Let's say we have a fracture that has maybe a slight oblique pattern to it towards the proximal aspect of the middle third of the femur.
good.
Look at the cam deformity on the femur. Nobody, huh? All right. That's cool. That's cool.
So yeah, you can already, that's good. So yeah, transverse to maybe a short oblique fracture here of the proximal to middle third of the femur. You can already appreciate that it's got some shortening going on. So Dr. Shuler had mentioned a couple things. Someone remember what the deforming forces are that are going to be acting on these fragments, and you can kind of see the position of the fragments is kind of giving away the answer, but what is responsible for that?
Figures.
The short external rotators or all your abductors.
Yeah.
Okay, so that's part of it. It's going to kind of rotate and abduct your proximal fragment. Anything else?
Yeah, you're also going to have some action by iliopsoas, kind of bringing that proximal segment to flexion.
Good. So you can see on the lateral that that proximal fragment is more anterior, it's more flexed to your iliopsoas. And then femur fractures are going to shorten mostly due to the adductors that are attached here on the distal fragment. So you're going to have shortening as well. Any other injuries or things you want to evaluate for, especially in a young person with a femoral shaft fracture?
Femoral neck.
Perfect. So definitely something that sometimes obvious and sometimes it's not. So certainly something you want to be on the lookout for and closely evaluate. These two x-rays I gave you probably, you get some sense of it, but not the best view. Oftentimes these patients have a CT scan of their abdomen and pelvis if they're a trauma that comes in. So it's a good way to kind of evaluate that beforehand. Anything we can do to try to make this patient more comfortable before we plan to do surgery?
Lisa.
You put him in skeletal traction.
Sure. So what are a couple options to do that?
I'd put a pin in his distal femur or his proximal tibia, either way.
Sure. Both are reasonable options. You want to make sure you have an x-ray of that area before you go putting a pin in there. But certainly a fracture like this would be amenable to a distal femur pin as long as there's no fracture distally.
Why does traction help?
It pulls it out to length, and it can keep the fragments from being as mobile and decrease bleeding, which would decrease swelling.
How does it decrease bleeding?
You don't have as much since the fragments are up to length, they're not going to be as mobile, and so they're not creating as much local damage.
Yeah, that's correct. That's part of it. It's a volume thing. So the volume of a sphere and the volume of a cylinder are different. So volume of a cylinder is radius to the second power. Volume of a sphere is like, I forget, third or fourth power. So you're exponentially decreasing the potential space you can bleed into by pulling it out to length.
And just kind of generally, obviously we've been talking about femur nailing a lot. What are some of the treatment options for this injury?
Yeah, so you could nail this. I think this one you could probably go retrograde or anterograde. I think it's mid-substance enough to do either. You could also plate it here, but I think a rod's a valuable option here.
Agreed. I think you could go either. You could argue either antegrade or retrograde for this one. I think both would be appropriate. So briefly, just touching on traction that we mentioned. So you can do either distal femur, proximal tibia traction for these fractures in general. Often we do distal femur as long as the fracture is proximal enough. So which direction do you insert a distal femur traction pin?
Medial
and
to
why?
left.
Why is that?
Because you want to avoid the femoral arteries. It snakes medially. So you look at what you're
Good.
pinning.
Good. So you have more control over where you start versus where you come out on the other side. So you want to start medial on the distal femur. Proximal tibia is going to be the opposite. You're worried about most significantly the perineal nerve. So if you come out too posterior, if you were to go medial to lateral for a tibial pin, that would be at risk. So you go the opposite direction. So for this case, we ended up doing a retrograde nail, like we mentioned. Someone remember what the start point was for a retrograde nail?
Right there.
Should be just anterior to Blumenstadt's line.
Good. So you can see it looks like we achieved that pretty well on the lateral here. What about on the AP?
I think we said, was it just lateral to the medial aspect of the femoral, or to the femur?
Just medial to the center of the notch. Usually what you want to shoot for. So you can see here, looks like we got a pretty good reduction. These transverse fractures, often you can get a pretty good cortical read. And we took the nail up just past the level of the lesser trope, like Dr. Shuler had mentioned. So as I was going through the fluoro shots that were saved from this case, I noticed that they took an x-ray of the left hip. Anybody have any explanation why that would have been saved?
Shows
What's the utility of that?
He's got bilateral FAI. Anybody?
You could use that to compare for rotation and alignment of your operative leg.
Nice try.
Good. So it's called a trope profile view. So there's multiple ways to assess for your rotation. So a common way to do it is to get a trope profile at the beginning of the case. So what you do is basically get a perfect lateral of your contralateral knee, and then hold that position, rotate the C-arm up to the hip, and take an AP of the hip there. So that way, once you have the nail in, you can, and lock distally, you can pull up this x-ray, look at the lesser trope, you kind of see the profile of the lesser trope, and compare that back to your one on the other side. That's very helpful, especially in a comminuted fracture where you don't have a good cortical read. On a fracture like this, you can use your cortical reads on either side to kind of assess your rotation, and that's a little easier. But on something like a AK-47 to the femur where you don't have that, something like trope profiles could be very helpful. We have time for one more, Dr. Wathney, or?
Well, just motor through it, and then maybe just show them what you did, and then we can go to
Okay.
Matt.
Sounds good. The first one was definitely the longest one. So this was a 27-year-old, fell about 30 feet while she was hiking around in Virginia. She was stuck for about 2 hours before paramedics were able to rescue her. When she came in, she had some ecchymosis over her lateral hip, but no obvious open injury. Nerve vascular intact distally.
You sure one of my
So you see
cases.
here. Yeah. Dr. Wathney should recognize this one.
Right. Well, I gotta
This
show
is
you.
our case from the weekend.
I know I'm nervous now. She was gonna judge me. We'll see.
Me too.
It looked great. That's why I picked it. Yeah. So subtrochanteric fracture on the left femur here. So you can see again the deforming forces causing some flexion, some external rotation, some abduction of the proximal fragment with shortening. So for this one, a little different because it's such a proximal fracture in terms of fixation options. So you're probably not going to do a retrograde for this. It's too proximal in order to get the fixation you need of that proximal fragment. So Dr. Wathme and I think it was Michelle.
It was Michelle. And
tries to use a recon nail in this case. So one tip you can use to try to get your reduction on fractures like this is to make a small lateral incision and use a bone hook to slide over the top and grab your proximal fragment there. So they were able to do that, get a great reduction, and then use a piriformis entry, it looks like, with a recon nail with 2 screws going up to the head. And it looks like it came together nicely.
Except we have 180 degrees rotation distally.
That looks great. That's a collinear clamp, and that's a great technique. I'd almost call that a variant of a reverse oblique intertrope.
Yeah, it was a tough one. Thank God Michelle was there. So yeah, the collinear clamp though was my idea. I think that came from Dr. Shuler. I don't know.
That saved the day on that case.
These are tough, man. There's a lot of deforming force you're trying to correct. Well, it's good stuff. Any questions about femurs before we talk about Roanoke? All right, Deasey, you're up, my friend. You here? Let's see what kind of t-shirt Deasey's wearing tonight. Or did he disappear? Is he still around?
Can you guys hear me?
Oh, I do.
Awesome. All right. So let me get to screen sharing here.
So are you on
Sweet salad, Deasey. That is nice.
It's very nice. Dr. Shuler has offered to give me a haircut.
I think you should take him up on it.
Yeah. He would do it very quickly, and it would be very stable. How can I share my screen?
Oh, come on, man. Like we're 9 months in this pandemic. You gotta know by now to share your screen.
I just like to share my voice.
That's coming to us from COVID Central there at the hospital.
Yeah.
That's right. Here we go.
All right, Matt. What do you got?
Share screen. Oh, you press the button that says share screen. I understand. All right, here we go. So we're going to talk a little bit about life in Roanoke, which is pretty great. I'm on call, and I still feel like life is pretty great down here. All right. So on this map, you can see Charlottesville circled in UVA orange, and Roanoke circled in some tech maroon or purple. I don't know what Virginia Tech's.
Hey, Matt, unmute one of you have 2 speakers going, it seems.
Can you hear me here?
Yeah.
Okay.
You have like an echo going.
All right, I'm going to toss this one far away. Is that any better?
Try that.
There you go. How about that?
Perfect.
Okay. So it's about an hour and a half to get from Charlottesville to Roanoke. It's a pretty beautiful drive. You can go pretty quickly, and you just have to watch out for trucks on 81. But easy to get home if you have to get home after a long day or on a post-call day. You can get back and see your family in Charlottesville. But Roanoke, when there's not COVID and quarantine, is a pretty great place to have some fun in the outdoors, and it's an awesome place to be a resident. So this is a view of the Mill Mountain Star. It's the most recognizable sort of Roanoke feature, and it's an awesome place to ride bikes, run, just enjoy some nature. And the hospital is right over on the other side of the ridge. So if you want to hike at the end of a long day, you can absolutely do that. I wouldn't recommend that in the winter because it's dark, but otherwise the sunrises and sunsets are pretty fantastic. This is just an example. We're talking about nailing. I just added this. This was from Sunday. This is a retrograde nail for a just 5 mile long spiral distal femur fracture in the setting of a prior DHS. And Dr. Seaman, who's a protege of Dr. Shuler and also a former UVA resident, was the attending on this case. And it was just a great example of how well a nail can fix a femur fracture if you do it with proper technique. So this is Pebble Creek. This is where you stay when you live in Roanoke. We have 4 apartments, one for each of the residents from UVA who's down here. The pool does not look like that right now, but it has in the past, apparently. It's about 11 minutes from the hospital at most. You probably get there in 8 or 9 minutes without any issue. The rooms, I think that's probably Michelle's apartment that's a picture of. Nobody else's apartment looks like that. Mine still has some hair from when Dennis Chen was down here last, so maybe I can add some salad. But the apartments are 2 bedrooms, so you can bring your family down. You can bring your friends down if you want, although they probably won't want to come. But you can I have a wife and 2 children and a dog, and they can come to visit without an issue. And there are more TVs than you know what to do with in the apartments. So Dr. Guafmi and David Craig have hooked us up with a lot of flat screen TVs. So you may just find an extra flat screen TV in your closet. So I like to think of Roanoke as like surgical boot camp. So there's a little combination of the true camp feel up top and sort of like a basketball camp, summer league feel down here. So if you think about Dr. Guafmi and Dr. Chabra, Dr. Bachman, they're like the head coach of your team at school, who really, have known you since you were a freshman and know everything about you, both your skills and your deficits. But when you come down to Roanoke, you have an opportunity to sort of reinvent yourself and apply all the things you learned during your first 2 years of residency in a really focused environment, like you're away at a summer camp and can really develop before you come back home to UVA and do what Michelle did on call with Dr. Guafmi and fix that femur fracture perfectly. So I think coming down here is a great opportunity to really develop your skills. So here are the 3 trauma attendings who do sort of exclusively trauma stuff, although Dr. Shuler does do arthroplasty. So Dr. Shuler is a master of all things orthopedic trauma. Dr. Caniglione is a fantastic surgeon. If you have any question about whether or not a DO can operate, you hang out with Dr. Caniglione for a day or 2 and you see that he's a fantastic surgeon, an incredible teacher, who's very patient and will allow you to grow more than maybe anybody you work with in the trauma setting. And then Dr. Seaman is a former UVA grad, and he's just an amazing guy to hang out with. He'll tell you amazing stories about UVA's residency that Dr. Guafmi may or may not have shared with you before. He's also a great teacher and a great surgeon. He's recently lost a full residence worth of weight, and now he's very fast as well, which will come up. So there's a lot of time for recreation down here on your post-call days. So that's our trauma setting. Here are some hand attending. So Dr. Apel is an MD and a PhD. He's also a hand surgeon and a pediatric surgeon. So if you want to come down and do a mini hand fellowship as a PGY-4, you can spend time with these folks. And it's a great way to get exposed to upper extremity trauma or even arthroplasty. So Dr. Bravo, Dr. Mearsh are both Mayo fellowship trained hand upper extremity surgeons. So you can see everything from microvascular surgery, hand upper extremity trauma. You can see reverse total shoulders, anatomic total shoulders with these folks. They're very patient, very skilled surgeons. So Dr. Owen is a traumatologist trained at Harvard. He also now does some anterior hips, and he does it not on a traction table of any kind. So it's a new technique for us to learn as residents, something we really enjoy. Dr. Koobs is a WashU, Minnesota guy who does arthroplasty. He says he can do any joint that's a ball and socket. So he'll do shoulder arthroplasty, hip arthroplasty, in addition to total knees. And then Dr. Tuttle is a sports guy down here who taught me how to do a quad tendon ACL. I'm sure Dr. Guafmi would have taught me if I had the opportunity to work with him this year, but I'm a PGY-4, so I would do it with Dr. Tuttle. So this is just a sort of a peek into a standard day in Roanoke. So, if it's a slow day in the fracture room, you can finish up by 1:54, go for an awesome bike ride. Up here, you can enjoy the Blue Ridge Parkway or go for a run along the Greenway. You can see the river running right in front of Carilion. There's a Greenway there. And then you have to be back on call by 5 p.m. and you come and see an APC3 pelvis, which I've seen, I think 3 or 4 of in 3 rotations down here. And you can work on your external fixator skills, your pelvic binder reapplication, because the trauma surgery team here, like everywhere else in the country, puts the pelvic binders on the on the belly. So you can put them on the grave trick. Here's an example of our schedule. It looks pretty complicated, but I'll talk a little bit more about it. The thing to focus on would be the orthopedic resident assignments. So there are 2 4s, 2 3s, and a Larkin resident. And then we sort of take call on the rotation you see at the bottom. It's a little bit busy, so let's look here. The way things are organized, is that there are 2 fourth years, chief resident, which is my role right now, which means I'm responsible for the schedule and making sure I give everybody the exact day and time off that they want and cause no problems for them. Particularly the plastics intern needs a lot of vacation. So there's a 2 fourth years from UVA, 2 third years from UVA. The 3rd year ED resident is on call during the day every day, unless he or she is post call, in which case the 3rd year float resident takes daytime call. You have awesome assistants. So I'm on call with the podiatry resident tonight. Avery's a fantastic resident, has learned a ton about orthopedics. There's also a Larkin, Miami orthopedic resident who works with us, as well as a plastics intern and emergency department PGY-2. These folks take primary call, which means they hold the equivalent of the service's intern pager most of the time, unless they are on vacation, they need some time off. We don't want to overwork them. So there are times when I'll be the only person on call. But oftentimes you have somebody else to help deal with floor pages and to help you do everything you need to do overnight. So this is, as you can see, people really enjoy their time here. We have Harrison, Max, Dennis, looks like a Larkin resident who I didn't get to work with, Dr. Carilion, Dr. Owen, Dr. Shuler, Siraj, and Dr. Seaman. That's before he started running 18 miles a day. So don't worry, he's fast now. But you can see people are really enjoying themselves here. People work very hard, but getting to work with somebody like Dr. Shuler, Dr. Owen, Dr. Carilion, Dr. Seaman, their patience is fantastic in the operating room, but they also expect you to know how to operate. So you take all the great stuff you learn as a PGY-1 and 2 and early part of your 3 year at UVA, and you get to come down here and show the attendings that you've learned something and really refine your skills. Just an example of what we've done this week. So on Sunday with Dr. Seaman, I was on call. We did revision, below knee amputation, a knee spanning X-fix. We did a tibial nail. We also did an IND of an open tibia and plated it before the neurosurgeons and the anesthesiologist could put a central line in the patient. So that proves what I always have thought about spine cases, which is that you can do an entire orthopedic case before the spine case is ready to go. We did that retrograde nail I showed. And then on Monday, there was a big thigh IND, a knee IND, a patellar tendon repair, a little distal radius, and then there was a big laceration that got a bunch of tendons. So we did that on Monday. On Tuesday, we did distal radius, a hemi. The hip CRPP actually turned into another hemi, but then a short nail, and then Dr. Shuler fixed an elbow. And then just yesterday, there was a pediatric humerus, or no, it was today, actually. I skipped Wednesday because that was post-call. There was a pediatric humerus, a peds floating elbow, a tibial plateau, and I did 2 P-lines with Dr. Evans and Dr. Carilion. So you see it all. You know, I don't think there's any holes in the orthopedic trauma rotation down here, and it just helps to augment everything that we learned back home. I love my family very much, and I still enjoy coming down to Roanoke, despite having to be away from my wife, my daughters, and my dog, because of the people you get to work with down here. So I would say for me, it was the thing I was most worried about in ranking UVA number 1. Dr. Gwathmey can confirm that I really wanted to come to UVA. I sent him about 50 letters about how much I loved it, but I was always worried about Roanoke, and having spent 37 weeks down here, I can tell you that it's a wonderful place, and you'll be really lucky if you get to come here as a resident and work with these attendings. And that's what I did this morning. We started late with our cases, so I got in a 3-mile run this morning. Dr. Seaman started early because he had clinic today, but there's plenty of time to exercise, and all the recreation you could ever want is near the hospital. But more than that, you get to come down here and really become a surgeon. So you can fix that plateau and then go for a bike ride with Dr. Carilion later in the afternoon. That's it.
That was great, Matt. Yeah, I mean, as someone I've spent my 40 weeks down there. Surgical boot camp's not quite the right thing, because you just learn about how to be a doctor. And I think the other thing that Matt didn't really touch on is that it's a whole different approach down in Roanoke from a UVA when you're an academic center. Most of you guys, when you go into practice, will not be going into practice in a place like UVA. You'll be going to a place more like Roanoke, or a hospital system like Roanoke. So I think it gives you a great second perspective as far as how it is to be an orthopedic surgeon. So I think that's another added advantage to it. So you're home on weekends. So every other weekend you get like a golden weekend. Are you taking us on a tour now, Matt? You going to the cafeteria?
This is the attending office in here. So this is Dr. Shuler's seat. You don't want to be sitting there, but you want to make sure the images are up. Very cool. I just want to get away from the echo. I would say that that's a great point by Dr. Gwathmey. You really do learn how to be a doctor down here. Dr. Shuler's not just a wizard in the operating room. He also has a great clinical sense for everything about patient care.
there's no services down here. So back home, you know, you're on trauma, you're on joints, you're on foot and ankle, and you sort of round as a team. Here, you round on your patients that you've seen as a consult, patients that you've operated on. So it really helps you to take ownership of somebody's care from the time that you meet them as a consult until the time that they go home.
From the standpoint of an attending, it's tangible when people have been to Roanoke when they haven't been to Roanoke. So when Matt Deasey was like a PGY-2 that he could hardly tie his shoes, he would have one Roanoke rotation and came back just nailing femurs in like under 20 minutes. So so it really is, it's a tangible difference when they go down there. The confidence you develop down there, because the autonomy you're required to have can be pretty crazy. So like they expect you, the attendings expect you to be able to do these cases skin to skin. And so you'll find that out pretty quickly when you're down there. And so if you're not ready for it, then you sink. But if you're ready for it, you get an opportunity really to shine. So again, I think it's really it's the diamond of our program. And I think that when I was a rotator here, Roanoke to me was also, I thought was a problem, because I was like, I don't want to leave for 40 weeks and get away from my wife or whatever it might be, or my family. But it ends up being such a positive experience that really, and honestly, it's kind of nice to get away for a little bit and go down there and kind of do your own thing and really be able to focus on orthopedics for just 24/7. So great. Any of the other residents have any comments? And Max, Michelle, you on there? Do you have any comments about what your experience was like there? Emmanuel, I know you've been down there.
Yeah, I'll echo everything, and I'll just say I'm insanely jealous that Matt's down there right now. So that's how I feel about it. I wish I could go back again as a chief. That would be awesome. But,
you know what I'm jealous of? That slide where he showed the 4 people, like the 4 ortho residents and like the 10 people underneath them who take call for them. That wasn't always that way. When we were down there, it was just the 4 ortho residents. And so we did all the calls. But anyhow, it's a great experience. Awesome. Well, guys, Dr. Shuler, that was really, really great. I really appreciate you coming on. I think it just kind of shows the investment that Roanoke attendings have in the program as well. I'm sure Dr. Shuler would say he enjoys having us come down there. At least I hope he likes to have us come down there. But really, honestly, that was a great talk. I think it should be a required viewing for anybody taking care of any femur fracture. Should be able to watch Dr. Shuler's talk. Zach, thank you for your cases, and Matt, as always, thank you. All right. So anyhow, so next week's going to be, I think we have spine next week. And honestly, spine, the last curriculum, spine really brought it. So I expect to have some really good stuff. Okay. I'll send an email out tonight about this recording, and I'll give you some updates about next week. So look forward to seeing all y'all. Thanks again for coming and joining us. Okay. All right, y'all have a nice night. Thanks again, Ted.